inspire you to do anything. All right. So, I'm not a very efficient surgeon.
Further enhance our capital efficiency.
But I want to avoid wasted effort.
Air getting left and right.
Things like
There
air
are
dipping.
companies out there
I want to make forward
who
progress
want to
every
get
time I'm
bigger.
in surgery.
There are
That to me
companies
is
out there
really
who want
what
to get
matters for
small.
efficiency when I'm in the operating room. So you got to have a plan. You got to fight with your head. Nutrition's hugely important. These patients, like Amelia referred to, that's a lot of my Michigan patients. I need to basically optimize them to heal. I have a hard cutoff for operating on an elective case, which is 7.3 for an A1C. And sometimes the right surgery is actually not going to be a cuff repair at all. So again, you really need to focus on what the patient's telling you. Is this an acute on chronic situation? And hopefully you can figure out how someone's going to heal or not. And allow the patient to tell you what's wrong. This is a patient that was sent to me because she failed her cuff repair. But I asked her SSV and it was 95%. I respectively said, you don't need me. So how do I treat these things? So I have a sequence that I go through, and we're talking about large, massive tears here, very often acute on chronic. So 99% of the time, I cut the biceps every time, except for when I want to use it to augment my repair. Otherwise, we're going to cut the biceps and then transition to doing something next in line intra-articularly, which is going to be the subscapularis repair. I do repair it every time, even if it's a small tear. The exception when I don't do it is if somebody has some more advanced arthritis than I was anticipating. So then I move anteriorly to the tenodesis portion. I do it arthroscopically in the groove, and this also allows me to begin capsular releases around the base of the coracoid, because eventually we're going to need to mobilize these larger tears. And then I move posteriorly in the subacromial space to begin my decompression and get rid of the bursa, and then laterally for everything else.